So thank you so much for that wonderful introduction. It's a pleasure to be here. Thanks for inviting me to Tufts. I'll sign up for your mission statement anytime. That is just a wonderful mission statement, and I think there is no solution for any of this crisis, whether it's Ebola or health systems or human rights. There's no solution for any of it without a large collaborative effort and innovation to solve these terrible problems that we're facing. So I'm going to talk about Ebola, but you'll see that for us, it isn't really about Ebola at Partners in Health, and Ebola kind of represents many of the challenges all wrapped up in an itty-bitty virus. I'm going to show you some names here. These names are Bumba, Yambuku, Kikwit, Milanandu, Kekolo, and Wekadu. Does anyone know what these names have in common? Yes? Yeah, these are many places in the world that have had Ebola outbreaks. These are not familiar places. These are not names like Dallas or New York. They're not names even like Kinshasa. They're small, forgotten places around the planet. And yet I find it very important to remember these names because I think it reminds all of us that health anywhere affects health everywhere. That the suffering and the hardship of people, even in a small village of Bumba, can affect Wall Street or can affect how we are able to live our lives. And if we don't feel that connected, then we will make gross and systemic errors. And I think that is what Ebola represents to us at Partners in Health, is a gross and systemic miscarriage of justice. That means that is what happens when we forget that these places, these forgotten places, have people, have families, and have the need for basic human rights, from health care to water and sanitation to education. And so remember these names and look carefully at these small towns that might seem insignificant but are impacting the entire globe. The history of Ebola is full of these small towns. Since 1976, when the first epidemic was documented in Yambuku in northern Zaire with 280 deaths and only 38 survivors, a terrible, terrible plague, but in a very small town that it hardly registered in any international publication. The outbreak lasted a total of 6 weeks, and this is probably because people were so isolated that there was very little travel or transit or migration to other areas, and so the epidemic was quote unquote controlled. But I don't know who among us would think an epidemic control can look like this with only 38 survivors. That's a cataclysm. And so this is what we consider epidemic control, and I think this is part of the problem with Ebola. We have allowed these kind of cataclysms to hit these small, remote areas that people don't care about and thought, well, it's controlled because it doesn't hit us. There have been now about 20 outbreaks. There's newer information between 1976 and 2013 when this epidemic started. The death toll of all previous outbreaks combined was less than 2,000 people. And so it was easy to think of Ebola as an exotic disease, as a disease that wouldn't affect anyone of note. But this epidemic is very, very different. This is the map from the United Nations, OCHA, the Office of Humanitarian Relief and Assistance, that gets together during these crises and gives us the statistics we need, and showing the map of these 3 countries, Guinea, Sierra Leone, and Liberia, very hard-hit areas. Wekadu was the town that this outbreak was started in, a very, not an insignificant, not a small town, a town of about 250,000 people that was at a crossroads between these 3 countries. And that is how the epidemic rapidly spread, and you can see this is Liberia going up here, Sierra Leone and Guinea. The sum total of the epidemic as of October 14th was 4,555 deaths. That's now old information. We know there are more. I asked someone at the CDC what is the number they use to actually estimate the actual number of cases versus those that are probable, suspected, and laboratory confirmed, and he said it's probably a factor of 3. So we think there have been somewhere in the neighborhood of 12,000 deaths so far from Ebola. And that's with very little international response, with very little treatment. 5 to 10% of all the deaths have been among health workers. Health workers are uniquely at risk. And the majority of them have been local nationals, Liberians, Ghanaians, Sierra Leoneans, who did not have the proper protective gear. They were left to care for the sick and to do their jobs without anyone really caring about the conditions in which they've worked. And I don't know how many of you have worked in developing world setting. How many people have worked in developing world setting? How often do you see that there's plenty of just gloves? How often can you actually wash your hands? How often would you actually find a face mask? The answer is probably never. And so if we accept never as our answer every time we think about healthcare in the developing world, Ebola and other outbreaks are going to continue. And I think that's what's so tragic about this. None of this is suddenly shocking if you unpack this and look at how weak the health systems are. So the estimated caseload by December may be as high as 10,000 new cases per week and 1.4 million people infected by the beginning of next year. This is the worst case scenario, 500,000 to 1.4 million patients, just shocking numbers, and this is not hysterics, this is real. So one of my friends said to me, the weird reality with Ebola is that there are two things that coexist. It is, in fact, the worst health crisis of our time, and we have no reason to panic. And how can you hold those two? Because we have reason to panic for the lives and the safety and the security of people who live in West Africa, but as Americans and travelers, we don't have a lot of reason to panic. And I think if we can hold both of those realities of the urgency of the epidemic in one hand and the need for sort of rational thought and cool heads in the other, it's an important sort of duality and dialectic to consider here. I also think it's important to think a little bit about the economic impact of Ebola. I know we have some people from economics here. It's very important that we have you on your side. This is an important tool for our advocacy. These are exceedingly poor countries. They can ill afford to lose a single penny. And yet we expect that the loss of revenue may top $1.5 billion in West Africa. These are not countries that have $1.5 billion. And so we are fortunate to have one of the co-founders of Partners in Health now seated as president of the World Bank, Dr. Jim Kim, who's a medical anthropologist and happens to run the bank. Lucky us, lucky for the Ebola epidemic, because he has kept this on the radar and been really a fighter for that, bringing all of us together, CDC, WHO, other implementing agencies with governments, and saying this has to be done for economic reasons as well as health, moral, and human rights reasons, because this is not only West Africa, this will affect Africa, this will affect the globe. We know that trade missions, for example, between China and Ethiopia have been canceled because of Ebola. Ethiopia is very far from West Africa. We know that tourism is dropping in South Africa because of Ebola. So if the entire continent, which is home to some of the world's poorest and most marginalized people, then takes another enormous economic hit, it really will cause massive suffering. So this is also an important part of the impact. I'm going to challenge you a little bit from what we call the biosocial approach. We have in our midst at Partners in Health a predilection to look at things from a social lens, an anthropologic lens. And I think it's very important because this is not about health, as the provost said. This is about society, this is about human dignity, this is about human rights, and I think if we just look at it from a medical lens, we would make a terrible, gross error, as I said earlier. But I'm going to show you just a little bit of how Ebola, we think, gets into a community, but we think. It is not known how Ebola gets into a community, but the first case of Ebola is likely transmitted from the fruit bat, either infecting an animal, monkey, or a deer, or infecting a piece of fruit through bat guano, and someone ingests that virus, and that is the first case. I don't know if any of you saw the movie Contagion, but it's sort of like that, okay? The rest of the epidemic is human-to-human transmission, the rest of the epidemic. Now, I challenge and would be excited to learn more from the environmental health people, environmental science people. Many people will also look at deforestation of the Lower Guinea rainforest as a reason this epidemic has spread so widely, and I think that's an important thing to look at as well. This is mostly in the Lower Guinea rainforest. Transmission of the Ebola virus is not actually that simple. You have to take care of sick people, right? So it's not by air, but you have to actually care for the sick. So far, there are no cases of Ebola where people don't know how they got sick. There are none. There are zero that we know of where people say, wow, I got Ebola and I have no idea why. Everybody has cared for sick people. How many nurses are in the audience? Nurses? You guys have a tough job, right? Nurses do some of the dirtiest and most difficult work in the hospital, and it's no wonder that with inadequate protection, many of the health workers who get infected are nurses. So, many of the 75% of Ebola's victims have been women. Why do you think that is? They're caretakers, right? They're the ones caring for the sick. So this has a gendered face. That gendered face is women who are caretakers in the families are the ones who are getting sick and dying of Ebola, 75%. So all infected people are not contagious until the onset of symptoms. So if you were exposed to Ebola at some point and you're not sick, you're not infectious. Infectiousness of bodily fluids increases as the patient gets ill. It is no wonder the caregivers for Mr. Duncan in the hospital were infected, but not his family, right? Because he wasn't that sick until he got in the hospital. He got sicker and sicker, and the virus level, the viremia, started increasing, and there was more exposure to infectious fluids. So all of this makes sense, and so it's cause for being serious, but not for being panicked. We were looking, my mom and I looked on the web the other day, and there was a person sitting in a terminal in an airport in a hazmat suit. I mean, it's absurd, right? But this is what people do. So, and corpses are highly infectious, which is a bit different than other infectious diseases, right? So that's something we have to take into account. And that transmission can also occur on objects and surfaces. And there have been some studies that show that the virus can even live up to a couple of days. We think it's more likely 4 hours, but surfaces need to be disinfected. So it's highly infectious. It's not a joke. It's not that it's just same as X, Y, and Z. It's a very highly infectious. But it is caregivers who are dying of this disease, not sort of the casual observer in an airport. The incubation is 8 to 10 days after exposure. Early on, people have fever, fatigue, weakness. I'm not going to go too much into this, but the importance here is the early symptoms look a lot like other things. Look like influenza, look like malaria, look like general GI maladies that people get all the time in Africa, that many of us get all the time. And so it can be hard early on, and it's very important to catch this early, and I'll get into that in a minute. And it takes 5 to 10 days before people get very sick and start to have the kind of Ebola that becomes very infectious to others. And the late symptoms, which are hemorrhage and encephalitis, actually are much more rare in this epidemic than in previous epidemics. So the care and treatment is simple: supportive care. Right now, there are no Ebola-specific therapies except a couple experimental things that some of our American and European colleagues have gotten, and no Africans have been advantaged enough to get. But the care is supportive, and so it is not really complex. But we also believe the care has to be psychosocial care, because this is so profoundly disturbing to family members, to people who survive. What is the kind of mental health care and psychological support that we need to provide for families and for survivors? So I'm going to show you a couple of things that are really burning me up a lot about this epidemic, and I think really mixing what we need to do. This is a very typical, you can see this is put out by UNICEF. This is a very typical poster. I was just in Liberia a few weeks ago. You see this poster all over. These are things that protect yourself, protect your family, protect your community from Ebola. This is what's called IEC, Information, Education, and Communication. This kind of bread and butter public health. I'm a public health person as well. We've all done this. We want to get messages of public health across to people. But for a second, put on your sociologic, anthropologic hat and take a look at this. Do. Always wash your hands. Always cook your food properly. Go to the health facility anytime you have a headache. Tell everyone you meet about Ebola, call for help. Anyone see any problems with those do's? Yes?
Go to the clinic if you have a headache.
So what's wrong with that? What's wrong with going to the clinic if you have a headache?
Because you might be turned away and you might catch Ebola.
Right. So maybe that's not the best thing to do right now. We don't know. We'll talk about that in a minute. The clinics are ill-prepared to deal with Ebola. We know that many health workers have died in contact with Ebola. I was made aware of a story in Liberia where the very first patient with Ebola walked into a big public hospital. 7 health workers got infected, 6 died, and the patient died. Okay, first case, the hospital was closed. So a lot of hospitals now are closing because of Ebola, because not only health workers have died, but they're afraid. They're afraid to do their jobs. They're going to stay home. They're poorly paid to begin with. They don't have the proper protective gear. And so your health center may not be open right now. And if you go and you might have Ebola, they may not be prepared to take care of you. So this message is a little bit folkloric, right? If you're telling people, okay, go to your health center, what are you going to do? We'll talk about that in a minute. There are some solutions, but this is the message that's going out. What other problems in the do column? The don't column is even worse. We'll get to that next. Phone, like you're assuming everyone has a cell phone. This is a disease of predominantly extremely poor people. Yes, cell phones are pervasive. Yes, a lot of people have cell phones. Many people don't have cell phones. Right? Many people don't have cell phones. They do give a cell phone number, so that's good. They may have cell phones and no minutes. I mean, it's sort of assuming a lot. What other things? Okay, so cook your food properly. I'm going to get to the cooking the food. So first of all, people might not know what it means. But why cook your food properly? What does that have to do with it? What does cooking your food have to do with Ebola? Today, with this epidemic, in 2014, with 9,000 people in the world infected and 5,000 dead, what does cooking your food have to do with it? Nothing. Why? So why is it up there? This is from the CDC and UNICEF. These are smart people who make these posters. Hangover for another poster. Okay, we'll get to that in a second. Okay, wash your hands, soap and water. People might not have water, soap. I mean, I'm not saying you shouldn't do these things, but this is not really, if you want to give people messages, you want to give them messages that matter, messages that they can do, messages that are going to work, right? So let's look at these don'ts. Okay, there's 6 things here. Do not touch people with Ebola. Okay? Do not touch clothes of people who had Ebola. Do not touch vomit, saliva, urine, pee, poo of people who have Ebola. Do not play with monkeys. Do not eat bushmeat. Do not eat plums eaten by bats. All right, tell me what the problem with this is. And why would I be ticked about this? They might not play with monkeys. Yeah. Right. No, I mean, this is the problem. And this is why 75% of those who have succumbed to Ebola have been women. If you are a mother, if you are a wife, if you are a sister, of course you are going to take care of your sick family members. Now, you can try not to, and that is the message that people are giving, and we're trying to give that message too. Try to get help. Try to find help. But if your child is vomiting and diarrhea right in front of you, what are you going to do? You're going to take care of them. So is this the right message? Can people do this? What is this going to mean to people? I mean, it's a very complicated thing. Touch clothes, bed clothes of people with Ebola. I mean, these are reasonable because if we could limit what people do in interacting with very sick people, this is the problem right here. Okay, this is it, those 3 things. We also then have to set up a system by which people won't have to do this. So we'll talk about what that would look like. But how about these other 3 things? Monkeys, bushmeat, bats, plums, yeah. Right, so bushmeat, by the way, I mean, these are societies that live in a rainforest. These are societies that hunt for their food. Okay, so if you tell people don't eat bushmeat, what's going to happen? They're going to starve. And in fact, many of the bushmeat markets in the lower Guinea rainforest have now closed, which means people have lost their livelihoods. Right, so you're going to put on top of the Ebola epidemic an epidemic of hunger and malnutrition. For what reason? Why would you tell people not to eat bushmeat? No, it doesn't save any lives. There are no lives being saved by banning bushmeat. Why? Where does that come from? It's not a myth. Comes from a lack of knowledge about how this epidemic is being spread, right? First transmission came from an animal. One transmission came from an animal. The other 10,000 transmissions came from what? Human-to-human contact. So is this what we want our public health message to focus on? Bushmeat, and why? So I think it's a really important sort of exercise to think about why. Monkeys, bushmeat, plums, you're giving people the wrong message, which is this is coming from bushmeat. I said to the CDC person, I highly doubt that this is 10,000 cases of individual bushmeat transmission. We know this is human-to-human contact. So what do you think's up with that? Why focus on that? You're spending now half of your prevention message on bushmeat, which is not the cause of the epidemic. So what is it about bushmeat, and why do you think this is important? Or maybe it's not. What's easier about it? Right, exactly. So it's easier to say, don't play with a monkey, then don't take care of your family when they're vomiting and dying in front of you, right? So maybe it's just easier. What else? Get hard with me, guys, because this is a hard question. I think the answer to this is much harder than that. A bias and a misconception along the lines of what? Who people are doing those kind of things? Poor people. What poor people? Poor black African people. This is an issue about race. This is an issue about otherizing people. This is an issue that makes it easy because we exoticize something like eating meat to make it seem like this is not going to come and get us. That's my analysis. Right? I'm no social scientist, but that's my analysis. And I think this has misled entire nations of people and misled them in a way that's harmful. Right? And that is a way that kind of exoticizes, pictures of bushmeat and rats and everything. This is a lot of malarkey, as Joe Biden once said. So this is the other thing people talk about funerals. Right? Has anyone heard about West African funerals? Well, everyone's in the paper all the time, West African funerals. What is it about West African funerals that are so bad for Ebola? That do what? Touch the body. Who's been to an American funeral? You touch the body? You kiss the body? Do you wash the body? Somebody washes it for you. You don't have to see it. Right? They wash the body, they dress the body, they do the hair, they stitch up the smile, they put on makeup, they do the whole 9 yards. But we don't say, oh, those American funeral rituals, they're so exotic. If those bodies had Ebola, I had a friend, my best friend in medical school, her dad was a morticianer. And I asked him, sir, what happens when a person dies? What do you do? He said, well, we inject the body with this stuff, formalin or whatever it is, to sort of solidify the blood, or I don't know what all. We wash the body, we dress them, we do their hair. We have a special hairdresser comes in. We put on makeup. We, make sure the face doesn't look too sunken. This is our American ritual of death. Morticianers would get Ebola, right? So, of course, what culture doesn't wash the body? There's none, right? There's none. No, but everybody prepares the body for the afterlife. Every culture. But if we make it this exotic, Africans, and I was talking to this guy, world Ebola expert, French guy, he said, you don't know, you don't understand, they're so exotic, these rituals, they hang around the body, they touch the body, they put the body in a chair. It's like, sounds like an Irish wake to me. Right? I don't think it's so much, so yes, we have to tell people that that's not safe right now. But it's like the bushmeat thing, really do we want to make that the focus? We have to safely bury people. We have to explain to them that this could be part of the risk for infection, and indeed it is, and burial teams are a huge part. But I think the messages around exoticizing Africans and poor people and, is making it kind of a crazy place to wade into when the reasons for this epidemic are far simpler. They're really about structural violence and lack of basic human rights. And we want to make it some kind of interesting thing. So is it bushmeat and exotic funerals, or is it this? Squalor. Squalor. right? If we accept that people live like this, of course it's going to be really hard to address epidemic diseases. You know, this is a picture from Haiti during the cholera epidemic. You know, this is the kind of standing water in which people are living in, and then we're saying, oh, we have to control cholera, and, you know, it's the behavior of Haitians not washing their hands. Really? You know, this is a mother taking care of her child, and, you know, on this open fire and trying to cook, and we accept this as well as normal. It's not normal. It's absolute indignified kind of impoverishment. And then this is where most of my colleagues around the world work, in a health center that looks like this. No gowns, no gloves, no electricity, no running water, no hand sanitizer. Of course these guys are going to get sick, right? So we really want to treat Ebola, but the exotic animal I care most about with Ebola is this exotic animal. What exotic animal is that? It's not bushmeat. It's a canary. Where is that canary? Yeah, he's going down into the coal mines, right? And this guy has a lot of protective gear on, the kind of protective gear we now need to treat Ebola. But in the olden days, they would bring these canaries down the coal mine to see if the conditions of the coal mine were so difficult and bad that it would kill the canary, then they were not fit for human work, right? Ebola is the canary in the coal mine of totally disrupted and inadequate health systems, of a lack of health care as a basic right. That's our canary, right? Ebola is not so special. I mean, it's more infectious than any other disease I've taken care of, but it comes along these lines where there are these dangerous and noxious situations where people are working in areas that are not fit for human work, and then comes Ebola. These are the basic national health data, the demographic and health surveys that are done every 5 years in the countries that we're talking about. 980 women die out of 100,000 live births. That's 100 times more than in the United States. 100 times. So if I give this lecture in Guinea, or indeed to my team in Lesotho or in Haiti, and I say, how many of you guys know somebody who's died in childbirth? Every hand goes up. Here in the US, it's pretty rare. 9 to 10 women per 100,000 live births. This one, maternal mortality, death during childbirth, to us at Partners in Health, we say, is the report card of a health system. And these are some of the worst statistics in the world for women dying in childbirth, some of the worst in the world, right? So why would I say that women dying in childbirth, why would I say that is a report card for a health system? What's so report cardish about that? Because, you know, you could use under 5 child mortality, you could use HIV, you could use, but I think it's that. Yeah. What's that? Right, so you need health infrastructure to deliver safely. Why is that? Why do women die in childbirth? Why do they die in childbirth? What kind of complications? Infection, 1, so you need antibiotics. Hemorrhage, 2, so you need blood and a blood bank. Eclampsia, 3, so you need some antihypertensives, magnesium, etc. And obstructed labor, so you need a C-section, right? This is not a modern technique. C-section comes from the time of Caesar. Women in poor countries don't have access to these things. They don't have access to blood, to cesarean section, to antibiotics. And so as a result, childbirth is 100 times more dangerous in Guinea before Ebola than it is now. So these are the countries where we now have Ebola. This should come as a surprise to no one. This is a Google Mapper. I don't know if you guys have seen Worldmapper. This looks at the health expenditure per capita, and you don't even see West Africa. Right? West Africa is not here. This orange is North Africa. West Africa has completely disappeared. As you may remember, Africa normally looks like that. You know, the public health expenditure as percent of GDP is paltry. The out-of-pocket expenditure is, let's say for Guinea, $66 per capita. People don't have $66, right? So these are countries that have no health workforce. They have no health systems. They have clinics that have no drugs. And so this is how Ebola becomes the canary in this coal mine. There's also, what's the connection between war and Ebola? I'm not going to go into it, but these three countries had a very interrelated war. Civil war in Liberia and Sierra Leone, a military dictatorship in Guinea, many refugees between those three countries in transit, Charles Taylor using conflict diamonds, and much of this supported by outside powers. So, what does this have to do with Ebola? Does this have anything to do with Ebola? Weakens the infrastructure, makes the infrastructure that's already there worse, drives away the professional class, the people who would take care of the doctors, the nurses, the managers. Maybe they're killed, maybe they flee. There are more Liberian doctors and nurses, I would guess, in the United States than in Liberia, right? The president's son, who's a physician, is in the United States. So Partners in Health had not been engaged in West Africa. We had worked with two small grassroots organizations, Last Mile Health in Liberia and Well Body Alliance in Sierra Leone. For many years, we helped found them. We helped set them up. And they and the governments of these countries begged for our support. The heroes of this story so far is Doctors Without Borders, who has 700 treatment beds throughout the three countries. They've done an amazing job. But what they can do alone is insufficient. The governments don't have the resources or the personnel to deal with this. And so we have been asked to support these governments, and we are now engaged since about September 4th in a 5-point plan to really help to bring the Ebola outbreak to a stop, but also to address the underlying weakness of the health system, which is something I think Partners in Health does probably best. First is to stop transmission, right? The second is to actually treat Ebola, and they're sort of two different things. The third is to actually strengthen the health systems, because right now more people are dying of malaria than Ebola, and the health system has collapsed because health workers are unprotected, because many clinics are closed, right? To use the response to train health professionals and to generate new knowledge so that we can actually innovate and improve the kind of care that people get. Because right now the mortality is about 70%, and we think we can do much, much better than that, bringing modern medical care and new tools, new diagnostics and therapeutics. So this is what our strategy looks like. We have a large strategy that's community-based, community health workers. The HBRR is something that we're working on with MSF, with WHO and others, which is home-based risk reduction. We understand that a lot of these women particularly are going to be forced to care for the sick, even if we get enough beds open. While they're waiting to get those beds, what can we provide for these families to help them take care of those children and those loved ones safely while they're waiting for proper care? And so is there a way we can bring gowns and gloves and boots and chlorine and hand sanitizer and things that can at least help reduce risk as we are trying to get people to proper treatment? The second thing is the concept of an Ebola care center, which would be at primary care level, which would be a very decentralized approach so that everyone doesn't have to go to a capital city to go to a large unit, but you could get units to care for people closer to where people live. And then the third is at the district level, the Ebola treatment unit, which is the current standard of care that's being promoted by MSF. These are units of 100 to 200 beds where people come and get treatment for Ebola. We know that for this current epidemic, there are just not enough beds to treat everyone who needs it. The CDC tells us in their epidemic modeling that if you can't get 70% of people out of the community now, you can't stop the epidemic. So we need to have enough beds to get people safely to care. For us, stopping transmission means community health workers, community health workers, community health workers, people who are paid, who are compensated, who are trained to go out to the community to talk about Ebola and to find people early before they become very infectious, early when they have just mild symptoms and when treatment will actually help them. If you look at all of the cases of expatriates that have been airlifted out of these countries, the majority of them have lived because they've gotten treatment early. They've gotten modern medical treatment, but also early treatment. Early treatment also helps remove infected people from their families and communities before they're sick. And then, of course, stopping transmission also means the safe handling of the sick and the dead and adequate protection for health workers. And I can't really stress that enough, because our poor colleagues in Liberia, in Sierra Leone, in Guinea, they're sitting ducks to this infection. And if we can't take care of those providers, we cannot control the epidemic or the secondary effects. This is my colleague in Liberia, Lorenzo Dorr, who's worked for Last Mile Health for the last 8 years. He is a Liberian national. He lives in the community he serves, and he has trained hundreds of community health workers over his life. He's a trusted person. He's not a guy in a spacesuit. He's not wearing protective gear. He's going to houses. He's telling people about Ebola. He's encouraging them to get care if they're sick or if they seem to be at risk. And he is connected to the health system. He's not just on his own passing random messages, but if he finds something, he's able to refer people in via ambulance or some other kind of transport. I think this approach is critical, because if we don't use a compassion and solidarity approach to this epidemic, we're stuck with another approach, which is this kind of law and order and isolation and control, and that will not work. This unfortunate slide, you see this woman being pulled out of her environment, being forcibly sprayed down. Who is going to come forward for care that way? How can that possibly engender trust and have people want to come forward early? Versus this, sad as this is, there is care going on in this picture, right? There is care going on in this picture. So how do we orient our approach toward compassion and solidarity and understand that that is going to be our best security, is by making common cause with communities and bringing people forward. You know, Nigeria's success is quite amazing. That on the 20th of October, Nigeria was declared Ebola-free, had passed through 2 21-day cycles of contact tracing, and had not found a new case. But interestingly, so between July 25th, when an Ebola patient from Liberia died in Lagos, and we all thought, Lagos, game over. Right? This is a huge city. It's chaotic. Nobody thinks of Nigeria as having some strong health system. But between September 22nd, by September 22nd, so in that span of a couple months, 20 cases, 8 deaths, which, by the way, is a lower death rate. So they were doing something right. And then by October 20th, Ebola-free. So what can we learn from that? First of all, what we know is that Nigeria layered their contact tracing and Ebola efforts on existing health systems to track and trace polio and HIV. Investment in health systems was then leveraged to do something else. It wasn't starting from scratch. It was, and they hired and paid 150 contact tracers. They were not asking people to do this as a volunteer thing, do it for the good of your community. These were health professionals who were trained in public health, who were contact tracers, and many of them were community members. The health teams visited 18,000 homes. That is no small feat. And the tracing team monitored 894 people. This is a wonderful picture. This is an Ebola treatment unit that was put up in Lagos, Nigeria, that was never used. So they were prepared, but they didn't need to use it. So Ebola treatment. We believe at Partners in Health, and it's been our strong experience over many years of being involved in epidemic diseases, from cholera to HIV to multi-drug resistant tuberculosis, that if you don't provide treatment, people will not come forward and be tested. And so if we're relying on a lot of our early diagnosis and early case finding, that people will volunteer to be tested, if they're not getting treatment, they're not going to be tested. And so we can't just isolate sick people, and that's what's happening now. They're trying to drag people to forcibly put them in isolation centers where they know they're not going to get treatment and they know they're going to die. So if we can't have treatment, that's not going to work. And with early detection, we think treatment fatality may be less than 40%, even in resource-poor settings. And it requires tools: diagnostics, therapeutics, infection control. This is what an Ebola treatment center looks like. It is no small feat. You have to have an area for the very sick Ebola patients, a separated area for the less sick ones in case they don't have Ebola, so they don't get Ebola while they're there, and an area for the staff so that they can safely do their other work that is not related to the direct care of patients. This is inside an Ebola treatment unit, an MSF Ebola treatment unit, where people are getting oral rehydration. I think this is something at Partners in Health we know a lot about. We actually used HIV money for the last 15 years to revitalize health systems. We said, you know what, we can get this HIV money, and we can treat HIV, we can find cases of HIV, but who cares? Because even in the country we work that has the highest HIV infection, Lesotho at 26%, still the majority of people don't have HIV. They still die of stuff. They still have health needs. So what can we do? And we said we could do 4 things with HIV money. And this is what we aim to do as well with Ebola. One is put in essential drugs and tools for health workers. In this case, the personal protective gear that health workers need. But essential drugs, because people don't come to clinics because they want to find out they have HIV or Ebola, right? Most of the time people come because they're sick. And if you have nothing to provide them, they're not going to come. Second is we had to pay and train the health workforce. Right? In many of these countries, the health workforce is woefully underpaid or hasn't been paid in months. The Liberian workers who had Ebola squarely on their shoulders for months had not been paid in 6 months. The fact that they were working at all is so shocking and so heroic, it brings you to tears. They have to be paid. We have to fight for local workers to get paid. Third, we trained and paid and supervised an army of community health workers who could go out and do active case finding and psychosocial support and really be members of the community that could bring people in. And then fourth, try to get rid of any kind of fee for health service, which you cannot have for the very poor. This experiment in health system strengthening was done in Haiti, was replicated in 10 countries around the world, in 70 public facilities, and what we saw in every country was about the same thing, that health systems as they were like this, were totally empty, were completely underfunded, had no staff, had no equipment, no pharmaceuticals, and we did those 4 things with HIV money and went from seeing no patients a day to 300 patients a day. So we have to rebuild the health infrastructure. Now, this clinic doesn't exist anymore. Now it's a kitchen, and we have a hospital there. But even when it was a little bitty 2-room clinic, we could see 150 people a day, find all their HIV cases, et cetera. Now, Ebola is a little more complicated because you have to do proper triage outside the clinic, whatever. But people need to have access to regular health care, and we have to build that back as part of this epidemic. Otherwise, the secondary effects are going to be profound, and they already are. Right now, there is no safe place in Sierra Leone for women to give birth. All of the maternity hospitals are closed. Right now, there have been outbreaks of measles in Guinea. Right now, there are kids dying of malaria, totally treatable disease. So if we don't get this part right, the effects of Ebola will be even more earth-shattering. This is the Wekadu Hospital, the hospital which the epidemic started in. It's a hospital in Guinea that serves about 250,000. Many of you have seen hospitals like this in the developing world. Partnership with USAID, people have put money in this hospital and no running water. No running water. This is a hospital, Partners in Health. I'm not sure we'd be able to handle Ebola really beautifully, but we have space, we have infection control, we have places to wash your hands, we have gloves. We could at least start to think about it in a dignified and decent facility that has enough tools to start even the conversation. And then to do this, we're going to need a massive expat workforce. And I'm hoping that here at Tufts, with your great environmental sciences program, you can help us, particularly with WASH people, water and sanitation hygiene, because that's a big lack and a big need in this epidemic. That environmental health and hygiene piece is key. But as we are going to require a huge number of expats, we hope that those expats will also be teachers and stay long enough to help train the next generation of Liberians and Guineans and Sierra Leoneans and really build real capacity in this country to do infection control and surveillance and provide proper care, critical care, and all of the things that we're going to learn together doing this epidemic. This is the work we've done in Rwanda. This is my colleague Corrado Concheta, who worked with us in Rwanda for 5 years and now is going to be heading up our efforts in Sierra Leone. In a program he designed called the Human Resources for Health Program Rwanda. We have some colleagues from Tufts and elsewhere. It's a massive number of expats that are going specifically to train the next generation of Rwandan health providers, doctors and nurses. That's an 8-year program run by the government of Rwanda and saying, we want our own people to be experts, not just bringing in experts from the outside. And then the last thing is we have to use this as an opportunity to generate new knowledge. These diseases are neglected because they affect people who don't matter in the global economic system. we need vaccines, we need new diagnostics, and we're hoping that with colleagues in Liberia and Sierra Leone and Guinea, academics and other institutions, local institutions, we can put together rapidly vaccine trials, point-of-care diagnosis, and use novel therapies so we can minimize and mitigate the impact on people. Because if we don't do that, you know, we're losing a huge opportunity to improve care for very poor people. This is a picture from one of our projects in Rwanda where we have a large multi-year program called the Doris Duke, funded by the Doris Duke Charitable Trust to train Rwandans to be investigators. This is a Rwandan who's working on her master's degree, and she's working with families to optimize the package for malnutrition treatment for children. So I'm just going to end with this quote from Camus. This is really the worst health crisis that any of us have ever seen. And my brother, who's a historian and a scholar, he told me I better go back and read The Plague, and I did, and I found this quote. I have no idea what's awaiting for me or what will happen when all this ends, but for the moment I know this. There are sick people, and they need curing. Thank you. I probably can take some questions. I have time for some questions if anyone wants to ask a question. Or not, yes.
So I haven't thought of it until you were speaking, but thank you very much for the way. You know the river monsters?
Yeah.
So they have very good systems in place.
Yeah.
Isn't that right?
River blindness. So, yeah.
Okay, so I was asking about the river blindness eradication program
Yeah.
in West Africa, which has been very effective
Yeah.
and has a huge network, and they still distribute the
Ivermectin, yeah.
Yeah. So can that be used in any way?
For sure. I mean, I think any existing system should be and must be really leveraged. And I think that that's a great example of something that's a long-term, multi-year commitment to really try to address a very severe problem. And so I hope that those, the works of the people who've been involved will be certainly brought to the table for this. Yeah.
Hi. Yeah, I know your presentation largely encompassed Africa. There's been a lot of discussion in the United States because of the cases here about what we can do. I think it's been obvious that it's been revealed we are underprepared in case something would happen, and I think it's kind of revealing that instead of getting a real disease and medical expert to deal with the situation here in the United States and preventing the spread, we appointed a political hack actually to lead that up. But just on this issue, there's also been some very pointed remarks that come out from Dr. Olsterholm, who is from University of Minnesota, Center of Infectious Disease. And he is actually saying, look, the virus is operating on virus time. The response is operated on bureaucracy time.
I agree with him.
And something has to be done on the scale of a Manhattan Project to get a vaccine.
That's right. No, I totally agree with him. He's correct.
Okay.
Yeah. No, I mean, there's lots of great analogies like Mike's. The virus is operating like a virus and we're operating like a bureaucracy. It is true. People are making pledges and not following through. And I can tell you, even my own organization, we are very committed to go. And it's taking us more time than I like to get our boots on the ground. It's a complex situation. But bureaucracy, I mean, we have to move rapidly and we have to just really be willing to kind of go and figure it out as we're going along. Nobody knows how to do this at this scale. And I think MSF has been warning us of this for many months, so he's totally right. Yeah.
So I have a question about the feasibility of passive immunization of being applied broadly, considering two things. First of all, it's been shown to be effective to take blood from a previously infected individual that's been cured and to treat somebody. And secondly, considering survivorship is 30 to 40%, there are going to be thousands of individuals that may have that capacity. So the first part of the question is how feasible is that? And secondly, how would you organize that type of initiative to take locals that might have immunization and provide their bloods to treat other people?
So great question, and the answer is yes. I mean, Partners in Health has told the government of Sierra Leone that we will hire every survivor they find. to be involved in the response. So first of all, I think it's very important to engage survivors because they're immune. Most of them have immunity by 3 months after they're sick. Second of all, because they can be great spokespeople for the fact that it's not a death sentence and help people come forward and share their experience. Thirdly, because the disease itself and the degree of illness is going to be further impoverishing to families that are already impoverished, and if we can hire those people and spread some cash around, it'll have a very good positive synergy on the community. And then lastly, I think there will be a role for large-scale studies, using passive immunization from plasma. And I know the CDC is engaged. There was an outbreak at the Firestone plant, and there were, I know, 27 or 28 survivors, and they have already started to study that plasma. And I think that's going to happen. So I think it's interesting to see that the NIH is moving much faster than they normally do. So I think there is some urgency on the scientific community, which I'm happy to see. Same with some of the vaccine studies. Yeah.
Good evening. Thank you very much, first of all, for your very interesting talk. I completely agree with your analysis. I do have one question. When you were talking about the health messages being diluted and you emphasize too many different things, are you not afraid that by emphasizing structural change in healthcare systems at this time, you'll be diluting away from the message of treating now? We need 70% beds at least. And
no,
I say this because I used to work in Sierra Leone in a hospital with MSF.
Which one?
Imbo.
Imbo, okay. Good, thank you.
That hospital was closed last week,
Yes.
and it was still providing basic health care because basically, even with the millions and millions of dollars that MSF has and the capacity, they weren't able to manage to keep that open.
Yeah.
So if that's not possible, shouldn't we just get all hands on deck and
Yes.
only focus on one thing first and then keep the message?
I totally agree with you. So your point is absolutely right. Right now, the top priority is to treat Ebola. So the message I would give to funders, to colleagues at the government is the first thing we need to do is open beds. The message I'm giving to this scholarly audience is let's look at this holistic picture. But I think the urgency to get people in treatment is enormous. It's the #1 thing because we can't even open these clinics, these primary care clinics, unless there's beds available for Ebola. So it has to lead. We have to lead with Ebola treatment. So thank you for pointing that out. And I think MSF is very strong on sounding that call. And we don't want to dilute the message by talking about health systems as a general concept. But I think I want people to understand that this is part of the pathology, if you will. But I think you're right. Right now, we have to just treat and control this epidemic because people, I mean, the societies themselves are collapsing. Yeah.
I believe I heard like a couple of weeks ago from the CDC that Ebola can be treated through air. And number 2, what's being done for the infrastructure so they have water that they can wash with?
Yeah.
And then also, that's also a problem in this country, like in remote places like Arizona, Nevada, California, Texas. I mean, millions of people don't have running water.
That's right, yeah.
So,
so that's a great point. Yeah, so a couple of things. I mean, Ebola right now is not airborne. Could it mutate and become airborne? Yes, it's a theoretical risk. We don't think that will happen. It is, though, transmitted by droplets, and if you get a droplet on your hand and put it on your mucous membrane, or if you get it right in your mouth because someone coughs or sneezes, you can certainly get it, which is different from a technical standpoint than airborne. So I'm an infectious disease doctor, so I make some issue, but it's super infectious, and you certainly can get it if somebody sneezes directly on your mouth, right? So yes, that's there, but it's not considered airborne, and it probably won't be anytime soon. Your other point about running water and sanitation, you're right. I mean, I think the indignities we see that people suffer in some of these remote places in Africa are not dissimilar to the indignities people suffer here. Partners in Health has a program in the Navajo Nation where we have many, many, many people that we serve that have no running water. So I think all of this should be a call for basic human rights and basic dignity that includes water, sanitation, and health systems wherever people live. So I agree with you. Yeah.
Thank you very much for that wonderful talk. I wanted to applaud after every point.
You're the anthropologist, right?
I am the anthropologist.
Paul trained me well.
I wanted to ask you about the 75% figure for women in Ebola. Because I've read very different it's very hard to get disaggregated
Yeah.
data at all, and I've read very different figures.
Yeah.
And so I just wanted to ask you some more about that. Is that from Partners in Health itself? And
No,
I also
no,
want-
it's not from Partners in Health. It's also from stuff I read, and I agree with you that I'm not sure. I'm not sure of that. The data's all over the map.
Huge reporting issues.
But yeah, I mean, and again, I think that's less of a sort of scientific number than a sort of social causation number. So maybe I shouldn't say 75% and just say a lot.
I'm also wondering about burial teams, because
Yep.
that's men.
Yeah.
And I'm wondering if that might equalize that number a bit.
Well, hopefully the burial teams that are being hired now, who are largely men, are fully protected with the personal protective gear. I think the people who are presiding over the washing and preparing of the bodies before death are largely women. So, I mean, I think it would be an interesting thing to study about the, sort of the gendered face of the epidemic, and learn at least what we can from an ethnographic standpoint, if not the pure quantitative data, but what's the qualitative experience that women are having. So I think it's important.
Thank you.
Yep. Okay. Great.
For
Thank you.
a wonderful presentation. And I'd like to introduce Dr. Colin Oriens, who is a professor of biology and the director of the Environmental Sciences program, who will now introduce the panel.
I want to thank you again for coming, and I really want to thank our panelists for agreeing to speak today. And we have 4 panelists, and they're going to be speaking in this order, but at this point I'd like you to come forward and sit at the table, please. From the vet school, the director of the Center of Conservation Medicine, we have Dr. Christopher Whittier, and we're really pleased to have him bring a veterinary perspective to this. He'll focus on the importance of ecological knowledge when confronting this epidemic. From the School of Engineering, we have Elena Naumova. She is she's a big data person. She's going to show us how past and present data can help us manage this crisis. She's worked all over the globe thinking about the movement of diseases. And then from anthropology, from the School of Arts and Sciences, we have Dr. Rosalind Shaw, and she's going to focus on the social dimensions of this epidemic. As you gathered earlier, she's an anthropologist by her questioning. And then lastly, but not least, we have Dr. Margaret McMillan from the Economics Department, again from the Arts and Sciences, and she's going to explore some of the economic costs. So they're each going to speak in turn, and at the end of their short presentations, we're going to open the floor again for you to come forward and ask questions. So thank you very much. Chris?
Thank you. Thank you. It's very bright light up here, so it's a little bit disorienting. I want to thank Colin and Jennifer for organizing this event tonight. It's really a privilege to be here. And obviously, it's a very tough act to follow after speaking after someone like Dr. Mukherjee. I was asked to talk a little bit tonight about the sort of wildlife and environmental side of the crisis that's happening right now, and a little bit about sort of my experience and some of the work that I've been doing. So I just wanted to run through a couple of images and a couple of slides to talk a little bit about that part of the equation and that part of the situation. I think Jennifer and the provost did a really nice job of kind of highlighting the fact that in a lot of ways Ebola is a very sort of classic disease to look at from a One Health perspective, because all of the factors that are important with when we look at a disease like this are part of the situation with Ebola. So we have obviously the very strong human health component. It's also a very strong wildlife component that's kind of being forgotten a little bit in the current dialogue, and obviously an environmental component in terms of where the disease comes from and how environmental degradation has played a role in the current outbreak. So this should be a somewhat familiar image that Dr. Mukherjee showed a few minutes ago. I just want to spend a couple more minutes talking about it, because this is really, essentially, this is about all we know about the ecology of the Ebola viruses. So if you look at this slide a little bit more carefully, kind of on the left slide, we have what we call the enzootic cycle. So enzootic is the sort of the veterinary and animal equivalent of endemic. So we believe the best evidence is that Ebola in its natural state resides in bat populations in Central Africa. And it's still a bit of an open question, and when I say I believe, or we believe, that's based on some preliminary studies and years of investigation, looking at animals during the outbreaks, and just a couple of hints that bats seem to transmit the virus. Very often you can find them with antibodies, but it's still not a very clear picture. But sort of the best evidence is that that's kind of where Ebola usually is, when it's not causing outbreaks. Essentially what happens is that the virus sort of gets outside of its natural cycle and falls into other populations. So Dr. Mukherjee talked about the human cases in the sort of the initial case, or the patient zero. I would argue that the patient zero actually is usually in another wildlife population. So in a lot of cases, patient zero from my veterinary perspective might be the gorilla or chimpanzee that actually gets the virus first from a bat spillover event, or in some cases the dikers in these forests. So part of what happens is that for reasons that we still don't really understand, you get a spillover from this normal bat population into these wildlife populations. And it could be that gorillas are eating fruit that's been contaminated with bat feces. It could be that chimpanzees are eating animals that have consumed bats or eating bats. There are lots of different theories and lots of speculation about exactly how that's spilling over, but it's still not very well understood. What we do know is that most of the time when humans get infected, it's coming directly from the bushmeat trade, and Dr. Mukherjee pointed that out pretty obviously, that that's usually the source of these human outbreaks. So that people are eating, in a lot of cases, dead great apes, either that they've found dead or that they've been hunting and caught animals that might be sick or dying from Ebola in the first place. So I'm going to come back a little bit and talk about that part of the equation. And the other thing to remember is there are other animals that are infected, and for the most part, the animals kind of on this side of the line, potentially including some species of bats, which is part of what we don't know right now. Are there bats that naturally harbor Ebola and don't get sick from it, and are there other bat species that actually die from it? That we don't really know. But these are all victims of Ebola in one way or another, similar to human populations. We talked a little bit about this question about Ebola, and I've seen these have been some headlines in the past couple of days. Is bushmeat behind the outbreak? And again, part of this is trying to, the media looking for stories. They're being in a sort of human natural instinct to try to find the blame or try to find the source. It's also obviously a very interesting scientific question here about where this comes from. But our answer to this from the sort of veterinary and ecological and conservation medicine perspective all along has kind of always been, of course it did. Either it directly came from bushmeat or it's come from something related. And either way, it doesn't really matter. And I think as Dr. Mukherjee very cleanly pointed out, once you have that initial spillover event into the human population, it basically becomes a whole other disease. It's a very different situation than that original factor. So there have been, increasing investigations and looking at and thinking about what's the original source. Starting to blame the family because the family was eating bats. And as Dr. Mukherjee again pointed out, this shouldn't be shocking to anybody. There's, the majority of people in these areas are eating wildlife in one form or another because they have to eat. And there's obviously been a lot of concern about how bats fit into this picture and trying to blame the bats. But obviously, if we didn't have bats, we'd have a lot less of the ecological system, including a lot of fruits and other things that are important for lots of human work. But again, this is really fundamentally a human-caused problem. So we're dealing with situations where deforestation is happening, populations are booming, people are eating animals that they wouldn't normally eat, animals are being forced out of their natural environments, they're getting degraded situations. Dr. Mukherjee pointed out this very interesting relationship with the war, which obviously is something that degrades infrastructure but also has a lot of environmental impacts. So there are a lot of basically human drivers behind this. Just want to point out that and this is in no way, by no means meant to lessen the severity of the impact of the Ebola outbreak right now that's happening in West Africa. But just in the grand perspective, if you look at, it used to be easy to find these sort of maps that try to show how the current outbreak fits in with the historical outbreaks, and each of the little dot is sort of the size representing the number of people infected. But if you look at the totality, it's somewhere in the neighborhood of 6,500 people that we know have died in the whole history of all the Ebola outbreaks. And that number actually pales in comparison to what we know from gorillas that have died from it. Somewhere in the tens of thousands. This circle represents about 15,000. So even sort of by this scale, and again, we don't know where the human outbreak is going to go. It could get to tens of thousands. There are scary predictions about possibly 1 million. But to this point, just in total numbers, it pales in comparison to what we know about gorillas. And bigger questions about chimpanzees doesn't even include dikers or other animals that we don't know about. So by comparison, that's quite a bit different. The other factor of that is thinking about how many gorillas do we have to start with. So this is just a quick map showing that where gorilla populations exist in Central Africa. And essentially, with all the gorillas, live gorillas remaining in the world can fit in a large football stadium. And so when you think about the impact of losing 15 to 20,000 from that population, that's basically somewhere in the neighborhood of 20 to 30% of the whole population. So until we get to sort of the billions of people that are being impacted by Ebola, it's still, on a comparison with the species level, it's still a much more devastating disease for some of these African apes. And this is something that we've been thinking about and worried about for many years. So you actually notice that, oops, this is a 2003 headline, with this idea that these Ebola outbreaks could be the death knell for African great apes. And just quickly, part of the work that I've been involved in, I was invited to be part of an organization a few years ago that was originally called Vaccinate, since been renamed Apes Incorporated, with this idea about vaccinating apes against Ebola. And so some of the work that I've been involved in with this idea that we can basically go out, find gorillas in some of these populations where they've been habituated. You can't see it very well, but there's a gorilla back there in the bush. In this case, using a blowgun, darting those gorillas. Again, you can't see it very well, but there's a darted gorilla. And in this case, we were using measles vaccine as a proof of principle that we could actually go out and vaccinate these animals in the wild. But this is pretty limited because there are only so many of these animals that are habituated that you can go out and find on a regular basis like this. And so, related to some of this work, we've been looking at trying to see what experimental vaccines that have been developed and tested might be effective for some of these populations of great apes. And there are a lot of issues, and I'm happy to talk a little bit more about this during the panel, about some of the vaccine development issues and some of the challenges that go into things like trying to think about how you vaccinate apes in the wild. And that's all I have. I was going to skip that one in case we have it for questions. So thank you very much.
Now we'll have Dr. Elena Nalmova. Elena, thank you.
Good evening, and thank you very much for staying for such a late time on a rainy day. But I believe the topic really deserves a very thorough discussion, and it would be really very great to start it with such a passionate presentation which we hear at the beginning of the talk. And what strikes me in this presentation, it's the complexity of the problem we are trying to tackle. And I felt that if we will think about national crisis, probably one of the side quotes which I found from Abraham Lincoln speaks to my heart really very closely, both on a personal and a professional manner. I'm really a firm believer as well in the people, and I believe that with solid facts and better understanding reality, we might find some solutions. And as a statistician and data analyst, I'm drawn by data, and I take my students to different countries in the world, not only to do research, but also to understand where that data coming from. And it's extremely important to make sense out of information we are gathering locally, which we try to process and understand later on. So from a point of view of crisis management, our Ebola outbreak already gave us millions of lessons to be learned. One of the most important ones is a crisis of communications and importance of communications. I'm not an expert in communications at all, but I see how often communicators use numbers. They are using for different reasons, for different spins. And I think that it's very important to understand what those information represents and how it's related to the real world. And with the Ebola outbreak, I felt that our understanding of complexity and the scale and dynamics of this process as well not allowed us neither to digest this information fast enough and carefully enough, nor collect really appropriate information to make judgment and make proper decisions. So even for some, it's a crisis of communications and lack of ability to move. To people like me, it's more of a crisis of primary data collections. And I'm really taking extremely seriously because if we'll think about how we can forecast what will happen tomorrow, day after tomorrow, about dynamics, about spreads around the countries, and decisions we need to make. We need to start with a very primary data information. Even for diseases which we think we know quite well, and for diseases we know how to control the situation, there are still glitches in many different ways. But with disease which just are emerging, and 7 years in a row, and even starting, considering that we start to have data in 1973, it's a very short time for scientists to understand correctly how to think about and how to forecast disease in a very, very fundamental way. So it's not only that our forecast and predictions are flawed and have really very strong structural issues, because if we don't have really a very reliable information on very basic parameters how we think about the diseases. We don't know if our assumptions about building models really met on the ground, and they might change from locations to locations. And if you see how it starts to change with respect to scale from tiny villages to countries, and for international travels as a fear of being exposed, that our modeling assumptions are really very weak at the current stage. And I'm not even talking about quality of data. We think that we have some data, but who knows how well it's validated and how fast they can change depending on different situations. And when we think about modeling infectious outbreak, we usually need to have whole entire process in mind. And it's about not only the outcome of the disease as a death or recovery, but we really need to understand the pathogen ecology, disease epidemiology, different treatment options if they exist, and prevention strategy, which one would be most effective one. You have on my slide on the left side all this very sophisticated equipment, and you will say, look, talking about resources, absence of bed, how we can talk about remote sensing, satellite imagery, different new technologies. But we have to be creative in terms of understanding what is available to us and what we are here can be offered. Not everyone can go to Africa tomorrow. Probably everyone can donate your own time and own expertise in different ways. So I think that even by understanding how novel technology can help to gather reliable data for predictions, it would be a very big step forward. But we don't have even the primary information, basic information where the infection struck. No information about census. It's very big difficulties in understanding what kind of resources exist, and especially resources which are related to sanitation and hygiene and the basic prevention and use of water resources. And of course, if I will talk about crisis management plan, if you will say, look, I came in a village, there is no health worker around, what kind of crisis management plan you're talking about? I have a crazy, crazy mathematical equations. And I don't have a time to talk about these equations, unfortunately. But my message with these equations and combinations with that, if we want to be able to control such a large scale and magnitude, we have to think about people on the ground suffer way more than us suffering to understand mathematical modeling. And mathematical modeling is basically the key. If you will think about S, susceptible, it's a who can be sick. E, exposed, it's those who already have exposure of diseases. I, infected, what is the probability of being recovered after being infected? H, can you have ability to be hospitalized and receive proper medical care? F, is this person will be in a funeral, so it will be lead to another wave of exposure. R, recovered. You see, like every single compartment of this model basically speaks to very specific actions on the ground for public health workers. And then maybe from this model, we will start to understand what is really probability of a spread in a much global way, and start to understand where we have to panic and where should not panic at all, and what is really the scale of emergency, and is it really possible to control it in a different type of way. And for me, the main lessons already are the following. We have to have a very, very steep learning curve in all aspects of dealing with emergency infections. And One Health concept is probably one of the best concepts we can move forward. I believe we need to think about have a system of rapid responses with solid, reliable data collections and processing schemes. Because usually we have hodgepodge of data in different places, we rarely have a system of collecting data overall and assessing data with respect to its quality. And I think that we need to move even from interdisciplinary approach to transdisciplinary approach. We need to have epidemiologists who have skills in novel technologies and who are willing and capable of working with computer sciences and with engineering to move forward ability to collect information on the ground and present this information in the most rapid and effective and efficient way. We need to have risk communicators who are capable to collect information with modern technology. We have to have statisticians who can translate results from modeling scheme to public health professionals and to policymakers. So we will have less strange conversations on a political sense. And we need to have medical engineers who have a vision of public health. So those who understand how we can basically build the surfaces which maybe will have properties for disinfectants of the products, how we can build handles on the door so it will be less transmissions of the infections, how to build protective gear so they will be, again, comfortable and easy to wear. And I will use this podium also for advertisement. And advertisement in the following way. We are working together as engineering school and multiple schools in Tufts University to build training grants, where we will be able to provide students with the new ideas, with a new system of courses, not only in United States, not only in Tufts, but also in countries with a low income. That is where the cravings are for many professionals, to have access to research, to knowledge, to communities where you can move this idea forward. And there are many other opportunities, including Bill and Melinda Gates Foundations. Wellcome Trust put really very important announcement about grants related to Ebola, United Nations foundations, and many other sources. And I believe both faculty and students have to be extremely proactive, capture the moment now, and move it forward.
Now we'll have Dr. Rosalind Shah talk about the social dimensions. Thank you, Rosalind.
Thank you, Colin. And thank you all for coming out on a dark and stormy night. And thank you for staying until the end. Thank you for your commitment. So this epidemic is unique in many ways, as you've heard, but it's also not a singular catastrophic event. People in Sierra Leone and Liberia are responding to it through the lens of previous layers of experience. The civil wars in Liberia and Sierra Leone, political repression preceding these wars, land grabs after the civil wars, and forms of structural violence, inequality, and marginalization that formed one of the most important causes of the civil war, and that intensify the Ebola epidemic. I've worked in Sierra Leone over a period of 30 years, and I've seen several of these layers. I'd also like to look at social dimensions of the Ebola epidemic. Here, I'd like to look at, very briefly, at how international responses are also shaped by prior histories. In the 1990s, there was an outbreak of post-Cold War conflicts, including the civil wars in Liberia and Sierra Leone. The US and Western Europe were reluctant to intervene. This was a politically isolationist era. So, and at this time, there was a spate of pieces in the international media that emphasized irrationality, superstition, deep-rooted traditions, and inherent violence, whether this was Bosnia or the DRC or Sierra Leone. And you can see these, the quote at the top by Robert Kaplan, who wrote the famous piece, The Coming Anarchy, in the Atlantic magazine, a piece that was faxed, that the State Department faxed to every US embassy in Africa. I call this juju journalism. It involves highly racialized and ethnicized representations with a strong political impact. It produced indifference. It was highly valued by the State Department. And interestingly, this kind of journalistic coverage faded during the peace-building interventions of the 21st century, when it was no longer politically relevant. But here's juju journalism again during the Ebola outbreak. So here are, as you can see from the second quote, reports about superstition, violent irrationality, disgust-inducing articles about bushmeat that create images of people as morally incommensurable with us, as fundamentally at fault and as not worth supporting. And this is basically a recipe for the plague village approach to Ebola. Now, within Liberia and Sierra Leone, it's not just the recent war that exacerbated the epidemic by devastating the infrastructure, important as this was. It's also the post-war priorities. The priority both for Sierra Leone and Liberia, and importantly for the international donors, including the US, has been military, has been security sector reform, rather than building a strong healthcare sector. So this has resulted in 80% of Liberia's health services being provided by NGOs. Sierra Leone does somewhat better, but it's a problem in Sierra Leone too. You know, how do you get a united, coordinated effort with when your healthcare sector is utterly dependent on foreign private NGOs? Another priority is that of what's euphemistically called foreign investment and otherwise called land grabs by a combination of international corporations, wealthy members of local elites, and national governments. They grow sugar cane to produce biofuel, produce palm oil. These are just two of several favored crops. They produce a lot of environmental damage, and so 30% of all arable land in Liberia and 20% of all arable land in Sierra Leone in 2012 was taken up by was lost to people through these land grabs. And these have been transactions, often without proper informed consent, through which people have lost their land and livelihoods. And only a fraction of the promised jobs have materialized. In some cases, the land has been drained and thereby rendered useless for the growing of rice, for example, which is the staple crop thereafter. Water courses have been changed. So the current crisis of government legitimacy that the current mistrust of the government, of the state that you've been reading about in relation to Ebola, it's not just irrational paranoia, it's not just ignorance, it's based on experience. It's based on experiences of the state as threatening livelihoods and therefore lives in exchange for foreign wealth. And I'd like to shift now to a specific place, to Makeni in Sierra Leone. Makeni is the fourth largest city, but the least loved town. It's been called the least loved town in Sierra Leone. Development, it has been kind of politically out of favor for some time for various reasons. Development usually reaches it after it reaches other major towns. During the war, it was occupied by the RUF rebels and the ex-Armed Forces Ruling Council junta, and the government sent a helicopter gunship to bomb it, including the civilian majority who lived there, because they felt that any civilians who stayed there during the occupations must be collaborators with the RUF. Doesn't matter if the civilians were unarmed and the RUF were armed, they were blamed. Now, Makeni has one of the highest rates of increase of Ebola in the country. So neglect spreads Ebola and intensifies it in places like Makeni. I'd like to start by reading you a story that was told to a friend of mine, Moses Kanu, who's on the left there with the two children. Moses is a Wesleyan pastor. I've known him for about 10 years. He was my research assistant when I was in Sierra Leone in 2004. And I'm going to tell you, he's now a Wesleyan pastor, and I'd like to tell you about the community effort, the community response to Ebola that he's involved in just a minute. But I'd first like to read you. He's been sending me emails, and I want to start a blog based on Moses' emails. He's been visiting quarantined homes. He's been praying with those who are quarantined and providing them with crucial psychosocial support, psychosocial care. And he's been listening to people, and he's been, with their permission, recording people's stories. So this is the story of a man called David. My wife was sick and admitted at the Madbente Community Hospital. She was pregnant and admitted together with other women in the same ward. My wife's sickness became serious, followed by frequent vomiting and stools. She died. I came back home and buried my wife. 2 days later, the report came from the hospital, showed that my wife had died of Ebola, and the house was quarantined. In less than 21 days, 7 other members of my family died of Ebola. Only 2 of us survived in this house. I am finished. I don't know what to do. I wonder when this pain will go away, especially when people around me are running away from me. Today, I attempted to visit my friends. As soon as I arrived, they all pretended as if somebody was calling them. They went away. How will I ever cope when my friends are running away from me? So Ebola is a disease that undermines sociality. It undermines the webs of social support that would already exist. All the preventative measures undermine the forms of social morality that are expressed through being together, by expressing support through touching, through hugging, through handshakes, through sharing. And it's engendering distance, a lack of contact, and fear that is leaving people like David kind of utterly bereft. On top of that, quarantined areas are suffering from horrifically steep rises in food prices, from water scarcity. Great hardship. These were often extremely fragile livelihoods to begin with. There have been, Moses, a couple of weeks ago, told me of the first suicide, when a man was left alone in a compound in which everybody else had been taken to a treatment center or a holding center. He burned himself alive. This is almost unheard of. And so when you die, you need to be with people. So the idea of dying alone under those conditions was unbearable to him. There are orphans remaining. According to a previous study of Ebola, in previous epidemics, children have a better survival rate than adults, a slightly better survival rate. So Moses is finding many homes in which all the adults are wiped out and the children remain. And the government is absolutely unprepared for this, with how we go forward, how we can imagine kind of building communities again with these kinds of issues. So these are the kinds of issues that Moses and the team of pastors that he's working with in McKinney are dealing with. They're trying to do their best to provide some kind of support, given that the webs of support that people have already built are basically falling apart because of this disease. They're also distributed, as you can see with the slide on the right. Here's a pastor delivering water to a quarantined family that has no access to water. And here, what we're seeing in this one town is are practices, as Dr. Mukherjee said, practices of compassion and solidarity. And McKinney is not unique. Just we're reading more and more reports about community responses, and Sierra Leoneans are extraordinarily resourceful and extraordinarily compassionate people. And even as they run away from friends like David, they're finding ways of kind of reweaving these kind of webs of survival. But they need the support of the rest of the world to do so. Thank you.
And now we'll hear from Maggie McMillan. Thank you very much, Maggie.
Oh, nothing like saving everybody's favorite topic for, least favorite topic for last. Thank you for coming. Thank you for being patient. Thanks to the organizers for asking me to do this. I have to say, I've been writing so much in the past year or two about all the successes in Africa. African countries have been growing rapidly. There's a new story about Africa rising, so I've been trying to ignore this Ebola thing, hoping it will go away quickly. So this forced me to sort of stop and take a moment to think about this. I will be very brief within the 5 to 7 minutes you asked me to talk. So it really is a humanitarian crisis. So why should we care about the economic costs? And Dr. Mukherjee, who did a wonderful job of inspiring us, and we're lucky that somebody with her smarts and passion has her eyes on this problem. The first is fundraising. These countries that we're talking about, as she mentioned, are extremely poor. They have more than half the population is living below the poverty line in these countries. And these countries need resources to help fight this crisis. And so you can't just go even to partners. You can't go to the World Bank or whoever it is you're trying to raise money from and say, you don't know how much money you need. You have to have an idea about how much money you need. And then the governments in these countries are severely strapped for cash. And they need to understand the costs involved for budget planning. Liberia, I have a lot of examples from Liberia because I was in London in late September and I heard the Ministry of Industry and Trade from Liberia speak. And so with the estimates of the costs of what they can do to fight the disease, they're making cutbacks in other areas. They're cutting wages. They're restricting fuel usage. They're banning unessential foreign travel. They're doing all of these things because they know that they need the resources to help fight the Ebola virus. And the third reason, I think, is to emphasize the scale of the problem, both internationally and nationally to local constituents. The best study I have seen estimating the economic impact of Ebola comes from the World Bank. It was put out in October 7th. And the left-hand bar graph shows short-term estimates of the millions of dollars of GDP that will be lost in Guinea, Liberia, and Sierra Leone. So the blue bars are 2014, and the green and red bars are the high and low scenarios for 2015. So in the worst case, in 2015, it'll cost $815 million. That's not very meaningful in and of itself. So on the right there, there's as a share of GDP, the hardest hit country is Liberia, which stands to lose 12 percentage points of its GDP. And for a country like Liberia, that means a lot of people falling back into poverty. How does the World Bank come up with numbers like that? So here's what they do. They have a lot of people on the ground in these countries. They have country offices. The offices are often staffed by locals, and as well as by expatriates. And so what they do is it's a national accounting exercise, basically. They go sector by sector, and then they estimate by sector what kinds of economic activity are being impacted by the Ebola virus. So they project a decline in agricultural output because less people are working in the fields. The mining sector has shrunk severely because the international companies who are working in those sectors have shut down temporarily. The manufacturing declines, they've estimated they observe a decline in cement production. They observe a decline in food and beverage production. Hotels are vacant. Flights have been restricted. They observe the declines in the service sector. And so they take these declines and then they estimate roughly the change in the growth rate by sector, and they apply that to the current GDP estimates and come up with the estimates of how much GDP will be lost as a result of this crisis. But the largest costs are really difficult to quantify. So they used a general equilibrium model to estimate the total cost to West Africa. They came up with an estimate of 32 billion because of lost labor, lost capital, lost trade between nations. Aversion costs, this is not funny, but I came back from Tanzania a few weeks ago, and I brought a friend a pair of earrings, and I gave them to her, and the friend who was there with us said, "You better be careful, you better wash those earrings." Those were from Tanzania. So, I mean, the aversion costs are all these things that people are crazily doing because they don't understand where the disease is and how you catch the disease. And for other diseases like SARS and H1N1, it was estimated that 80 to 90% of the costs were actually due to aversion costs. The human costs, lost lives, and plunging people into poverty. How do you put a dollar figure on that? We can. The medical costs, the related illnesses that will result from this. Failed states, I mean, in a worst case scenario, poor Ellen Sirleaf, who I happen to have worked with, she's battling not just this disease, but the opposition in her country who's doing things to discredit what she's trying to do to fight the disease. So in a worst case scenario where it can't be contained very well, you have the threat of a coup and civil unrest, and when that happens, you can't secure the borders. And I don't know what the cost of that would be. And then the last thing, which is really a pet peeve of mine, and it doesn't necessarily follow from all the other bullet points, but just putting the costs in perspective. I mean, Liberia's GDP is only $2 billion. Bill Gates' net worth is $83 billion. That's one person's net worth. Bernie Madoff took off with $50 billion. And the oil money that went missing in August from the Central Bank of Nigeria was $30 billion. I mean, what I'm trying to say is the costs of cutting this disease off right away are small in comparison to what they could be if we let it go out of control. And finally, I had been asked to talk a little bit about a post-Ebola plan, and I have no idea, but this is what the Minister of Industry and Trade from Liberia put up. This is their eight-point post-Ebola stabilization plan, and you know what's striking about it is it doesn't look too much different from what they would be doing anyway and what they need to be doing anyway, and it reminds me of what Dr. Mukherjee was saying. I mean, these are such poor countries. Okay, so they're going to rehabilitate their transportation infrastructure. This crisis, made it even more apparent what a problem it is, but it needs to be done anyway. Investment in electricity, agricultural stimulus plan, more than 70% of the population works in agriculture, a manufacturing stimulus plan. The only thing that's really Ebola specific up there is conditional cash transfers to hardest hit families. So, and it's going to cost a lot of money. So I hope that this crisis will be a wake-up call to the rest of the world that we need to do more to help the governments of these countries build the infrastructure, both human and physical, that they need to make progress in the 21st century. Thank you.
Thank you. And I now invite you forward to ask questions. For the audience, you can pose it to all of them or to a specific one. Well, why don't you do it? Because there are people watching, people listening online, so they'd love to hear your question.
I have a question for Dr. Shaw. The news media has portrayed in lurid details the stoning of healthcare workers by some of these rural villagers, and I wonder if you could address how the folks you know see aid from the outside and how they view what the Western press is saying about their behavior toward outside help.
Thank you, Stephen. Well, the folks I know are those on email, so I'm not getting a very good cross-section here. And the folks I'm talking to are horrified by the violence too. I think it's significant that that the reports of the violence have described young people as being involved in these often quite horrific incidents, and they're also in places that have a history of marginalization. So Wekadu, in what's been called the Parrot's Beak area of Guinea, in which kind of Guinea and Sierra Leone kind of wrap around each other, that has been it's been kind of historically a site of some of the worst violence and the worst place to be a refugee during the war. And so it's very interesting that again you have people there clearly feel even more at risk. And again in West Point, Liberia, an informal settlement of Monrovia, where you had the incident a few weeks ago in which you had kind of violence against a clinic that they tried to establish in that area, an extremely kind of marginalized part of the city that felt extremely threatened, that did not feel as if their lives were valued, that felt it was actually quite likely that their lives might be sold. I mean, if you're coming from a context in which the government has, in which you feel the government has colluded with those who have with schemes to take your land, it's not too far to believe that the government is collaborating with the WHO to sell your bodies, for instance. And there has long been a crisis of youth in this and other regions, in which, with fragile livelihoods and a neoliberal economy, 60 to 70% youth unemployment, the majority of youth are basically not able to become social adults, and they so you're a youth indefinitely, and then you die. Under these circumstances, youth have historically, especially male youth, been that sector of the population that has been most subject to kind of extractive exploitation. And that's not, of course, to justify the violence. This is to contextualize it.
Has anyone done any statistics for the probability of there being an outbreak in this area?
In which area?
In this auditorium?
No, like in Massachusetts or New England.
Oh. I can probably start with this answer. From what we understand right now, the probability is extremely low. But disruptions related to potential threats and real fear is enormous. You probably remember what just very recently a case where somebody will mention about, oh, I probably cough and I probably have an Ebola. It's turned immediately into the whole ordeal of taking people from airplane, have a squad. But if you will think about, again, amount of money spent on this type of activities, and if, for example, we are coming very closely to a flu outbreak, where probably everyone will be on airplane, either coughing or sneezing or have a fever, that you can actually imagine how much of a disruption it will come to even a small disruption, which will have a really very big wave. And I think it's really taking attention from many other very important activities and start to create a distrust overall to whole entire system. If, for example, you have a couple of false alarms, you will start to believe that this warning system works perfectly in different situations. So if it's come to probability itself is not really very high, it's in my opinion, but at the same time, all the disruptions associated with this type of potentials is enormously high and have a very big toll. Anybody want to add?
Do you know if Tufts, the hospital, is preparing for, isolation units or anything like that?
That I cannot comment, but I'm pretty sure that Massachusetts Public Health, our Department of Public Health, which we have a really very strong relation with, they probably will have a preparedness plan as they have for many other infections as well. So.
Do you have anything to add to that, Jennifer? About the hospital prep?
I was just going to say that the disaster preparedness and
So I have a quick question for Dr. Whittier. Dr. Mukherjee got us all riled up about that UNICEF flyer and talking about how there was only one transmission that came from bushmeat and the vast majority was human to human. And then you basically put a statistic up there that 30% of the gorilla population may be infected. And it's not that I'm really questioning her, but I guess I'm a little wondering about how to reconcile those two sort of statistics.
I think the sort of easiest explanation is that I think the point that Dr. Mukherjee was trying to make is that in the context of the current outbreak, the risk of somebody getting what would essentially be a first case directly transmitted from wildlife, bushmeat, a fruit that a bat had chewed on, whatever, is relatively negligible compared to the risk of them getting it from infected people and that they're coming into contact with on a daily basis. So essentially, what we know about the current outbreak is somewhere in the neighborhood of at least 10,000 people have been infected, and all but one of those people was infected from another person. So there's only one person in this outbreak who turns out to, by all accounts, have been a young child. That was the first case that with presumably that had that kind of contact. So I think the part of the message I think that she was saying is that in the context of this current outbreak, doing any of those things is not going to prevent the spread of the current outbreak, which is the real crisis right now. What I would say, the sort of flip side of that, is that with the knowledge that that's how these things spill over in the first place, that those are sort of going to be good habits to prevent future outbreaks, I guess is the easiest way to think about it. And but there's obviously a lot of context that goes into that. Yes, you can tell people that they shouldn't be eating bushmeat because of their risk of Ebola, but if the response is, well, what about my risk of dying of malnutrition? That's that's a much greater risk. So all this stuff has to sort of be put into context. I'm not sure if that answers your question.
Thank you very much. I do have one last question, which is that, if you were to think of the Tufts community staying engaged in this issue when it feels so remote for the most part, yet feels so immediate, what would be some recommendations for students and faculty to get involved at this point in time?
For all of us? Or?
Any one of you.
Well, they can organize a fundraiser. Every little bit helps.
So perhaps you could work with the programs to actually take donations for running the marathon. So I know I want to be cognizant of the time, and I really want to thank everybody again for sticking here till the end. I want to thank Dr. Mukherjee and absent. I want to thank the panelists. I want to thank the sponsors, the Office of the President, the Office of the Provost, David Harris for introducing our speaker, the Office of the Dean of Arts and Sciences, the Topin Bulwell Fund, Community Health Program, Environmental Studies Program, International Relations Program, Department of Biology, Department of Economics, Center for Interdisciplinary Studies, and the Tufts Institute of the Environment. Without those sponsors, we couldn't have pulled this off. And then lastly, but really important, the staff that worked so heroically to pull this off. Coco Sarah Gomez was amazing, as was Christina Log, and along with them, they got a lot of support from Kathleen Devine, Elizabeth Gottlieb, Katrina Noyes from the Provost's office, and Melissa Stevenson. So thank you so much to all of those individuals to help make this happen. And once again, I'd like to thank everybody.